Well, first of all, I'd like to thank Guillermo for his kind invitation to participate in this course. I'm Alex Fonollosa. I'm ophthalmologist, so I'll be the rare person in this meeting. And I work in the Department of Ophthalmology, and we have been managing patients with uveitis in a multidisciplinary unit during the last 11 years. So I'd like to share with you our experience and our philosophy when managing this type of patients. And I'll try to do it. Okay. So I'll try to explain our philosophy and answering these questions. What is a uveitis multidisciplinary unit? Why we think is the best way to manage uveitic patients, and how do we do it? So the what? A multidisciplinary unit for uveitis, it's a team of specialists from different medical fields, experts in uveitis. And I've underscored two words in this sentence, expert and team. We think that not only the ophthalmologists have to be expert in uveitis, but also the other colleagues who are involved in this team. And this is a team. What's a team for us? It's a group of people who work together, speak each other, have the same aim, have the same strategy, and agree with this strategy. This is important. In Cruces, how are we organized? Which are the components of this unit? Of course, an ophthalmologist, an autoimmune diseases specialist, in our case, internist, and because we also manage kids, a pediatrician expert in rheumatologic diseases. But it's important for us to be connected with other specialists, infectious disease specialists, microbiologists, immunologists, pathologists, because you know uveitis can be infectious. Perhaps sometimes we have to analyze smears, cultures, and this specialist for us is very important for us, just not to be expert, but yes, they have to be interested, at least, in intraocular inflammation. Why a multidisciplinary approach for uveitis? Easy to understand. First, diagnosis. You know, uveitis may be a part of the autoimmune systemic disease, so we will need you to diagnose some cases, as you will need us to diagnose other cases. Easy to understand. Second, treatment. You know, uveitis is a chronic inflammatory disease. Most of our cases need chronic immunosuppressive treatment. So we, the ophthalmologists, know these treatments. We know what to mirror, we know the pathology, we know contraindications, secondary effect, but we don't have the expertise. So it's very important for us that these treatments have to be managed by experts, by you. And this is for us a very obvious thing. This is very simple to understand, but I will say to you that some strange things are happening in Europe at this time. So I've been witness of these situations. I've heard a very prestigious ophthalmologist in Spain who manages uveitis saying, well, you know, I manage immunosuppressive treatment. It's easy. You just have to check a list of secondary effects which you're going to stick on your office, and you keep on checking. I've seen this. And I've also seen this in a very prestigious center of uveitis in Europe, where, you know, these typical weekly sessions of ophthalmologists debating, discussing what to do with an abnormal result of liver function. So I've seen this, and this is happening now in Europe. Comorbidities, another reason that can explain that these patients are better managed by multidisciplinary units. So these patients have comorbidities, diabetes, smokers, hypertension. So I think a global management of this patient, but internist, is very important for the patient, and the patient will be better treated. And logistics. So most of the centers, I would say, every hospital in Spain, every ophthalmology department in Spain do not have beds, do not have day hospital. So it's very important for us, your support, internist support for intravenous pulses, for biologics, and so on. So to sum up, I'm talking about the why. because of diagnosis, easy to understand, because of the treatment, because of the logistics, because of the comorbidities, and last but not least, because we are surgeons and you are doctors, and you have a very structured mind and very organized mind, not like us. We try to, but of course we are not. And we'll try to explain it with an example. So this was the case of a 61-year-old man who consulted for blurry vision in both eyes. His only relevant past medical history was some epistaxis episodes, and he presented with this clinical picture of bilateral retinal detachment with some inflammation in the fluorescein angiography. If you do not have contact with ophthalmology, this is a very interesting imaging technique, which is called OCT, which is a kind of scanner of the retina. You can see even the histology of the retina. And here you can see that this patient has bilateral retinal detachment, a very thick increase in the thickness of the choroid. And this is very typical of one disease, one autoimmune uveitic disease, which is a Vogt-Koyanagi-Arada disease. So what did our internist? She organized the methylprednisolone pulses, which is the treatment of choice in these patients. She sought for blood analysis, and not only that, 24 hours she read the results. And here you can see, you will know better than me, that this is a very abnormal formula. So the patient did not have a Vogt-Koyanagi disease. The patient had what we call in uveitis a masquerade syndrome, which are oncologic processes that mimic uveitis. So this patient had an acute leukemia. So seeking a blood analysis and reading the analysis 24 hours later, I would have never done it, and no ophthalmologist would have done it. So thank you to the internist for your work. So we are following with the scheme of the talk. We've seen the what, the why, and let's talk about the how, which it will be a more practice point of view. So we've seen until now that you help us with the treatments, you monitor toxicities, you offer us support with the logistics, you do it everything with a very structured mind. So you could think that we are vampirizing internists, and in fact we do. So we as ophthalmologists, or at least we try it, we have to try to take care of this relation because it's very important for us. So I will try to explain how we do it, how we try to take care of the internist to make this relation not only acceptable but interesting and nice. It's difficult. It's very difficult because, you know, we understand that most of our patients do not have a systemic autoimmune disease. Behçets, we see Behçets, sarcoid, we see sarcoid, but most of our patients only have autoimmune uveitic disease in the eye and do not have any symptom outside the eye. So I think it's difficult. We try to transform this relation in a mutualism-based relation in which both specialities benefit from each other. And I would add that this benefits the patient. So how do we do it? How we seduce, or how do we try to seduce the internist or the pediatricians? Well, from time to time we are lucky because we do brilliant diagnosis of a systemic disease by the ophthalmologist. For some, what does it mean? From time to time there are some patients who are in the hospital with several symptoms, systemic symptoms, and nobody knows what that patient has, and then present uveitis. And we see the uveitis and we diagnose the patient. I would put you an example which is real. This was a 66-year-old man who was admitted for 12 kilo weight loss and asthenia, some blood tests with inflammatory parameters, no findings, and he was lucky because he presented uveitis. So this is the clinical picture, blurry vision. You can see here vitritis and inflammatory infiltration in the retina, some precipitate in the vitreous. This is an imaging technique which is called autofluorescence, when you can see pathology of the retinal pigment epithelium. This is the OCT with these abnormalities in the outer retina. The other eye was normal. So when we saw this patient, we had a diagnosis, because this is pathognomonic of syphilis. So we diagnosed the patient with syphilis. So we diagnosed the patient. Another important thing for us is to demonstrate we are not the current ophthalmologists. The people who do, the ophthalmologists who do uveitis are not the current ones. I mean, I'm sure most of you, in any point of your life, have thought about us, those as ophthalmologists, as those people who go to the private clinic to earn some money taking off glasses. Confess. Yes. But this in some times it's true, but in others it's not true. So we are try to be more scientific and demonstrate it. It's important for us to motivate the internists to share iconography. We are very lucky in ophthalmology and specifically in uveitis because we see the inflammation. So I was hearing the talk before the coffee about the fake lupus, the fake arthritis. They have pain, they have inflammation, no inflammation. This is not a problem for us. If the patient has inflammation, we see the inflammation. We don't have doubts. And we have several imaging techniques to document the inflammation, to assess if it's better, if it's worse. And because we are seeing pathology in vivo. And we can see more tangible effects of the treatment than probably you in some times, because for you perhaps that patient's getting better is that the temperature is going down or that the lymphocytes are going up, I don't know. But we see how the inflammation goes down. And we have iconography. This is a case of a sarcoid patient. He was on methotrexate, 15 milligrams, prednisone, 5 milligrams, and although he was with this treatment, he presented this, which is a macular edema, low vision. So we put him on adalimumab, and after 4 doses, the patient had no macular edema, and the patient said, "Now I see," which is very important. So, and it's a tangible effect of treatment. So another thing to motivate our internists is that we try to be their reference ophthalmologist for non-uveitic ophthalmic disease that may present their patients. For example, hydroxychloroquine controls, for example, steroid-related cataracts, and so on. So we try to help them with these other non-uveitic problems. And we also like to organize meetings, sessions with internists, with infectious disease specialists, with rheumatologists, and every 3 or 4 months we organize these meetings, which we have called Eusko-Uveitis, and this is a meeting where it's very motivating for all of the non-ophthalmologists, specialists. We present cases, we discuss, it's very interesting. So we're following up the scheme. Another important issue of the how is the ophthalmologist's message, which has to be with the diagnosis and with the treatment, and I will explain. In the old days, and I've seen this in the old days, the ophthalmologist used to say, "Hey, this patient has uveitis, could you please rule out an associated systemic disease?" Which was a nightmare for the internist. I mean, without more data, the internist, who usually studies a lot, went to the Harrison, studied a huge list of uveitis, and started to seek for several hundreds of tests and nothing. So this is the wrong way to do things. So which is the right way to do things? We try to give a clear and sharp, direct message, like El Padrino when ordering a murder, for example. So this patient has a chronic bilateral granulomatous panuveitis with multifocal choroiditis. Most likely diagnoses are 1, sarcoid, 2, latent TB-associated uveitis, 3, syphilis. And this is what we try. to transmit direct and clear messages. We also try to transmit which is the severity and the emergency. I'm talking about now the treatment. We try to transmit the specific circumstances of the patient. It is an only eye, thus the eye has previous structural damage, and we suggest a treatment. I'm speaking about suggestion because then usually the internist or the pediatricians assess the specific conditions of the patient, contraindications, and so on. And it's very important for us that you have, you have to understand our language and our vocabulary. Macular edema, neurovascular memory, vitritis, autofluorescence. That's why I said before that also internist and the pediatrician have to be expert in uveitis. So the framework, that's the organization. How do we organize? So the three sames, same day visits, same people every time, same place. Same day visit, same agenda. I mean, it has no sense to visit the patient one day and then, yes, in 2 weeks, the internist or the pediatrician will see you. No sense. Same day visits, same people, same doctors every time. These are chronic diseases, very severe in some cases, young people, and for them and also for us, it's very important that always the same doctor has to know the disease, has to know the patient and see them every time, the same people. And same place. I'm not saying same offices, but close offices at least. So how do we organize? We always see the patient first. So it's reasonable. So who sees the inflammation? We see the inflammation. Who assess the possible diagnosis? We assess the possible diagnosis. So we see the patient first, and then build a message. A clear message, and with this message we go to the internist and say, hey, this patient may have a Behçet, may have sarcoid, please diagnose it. And the internist will see all the tests he considers. There are some colleagues, ophthalmologist colleagues, that start here seeking for tests or wherever, and then when they see a sign, this is wrong, they go to the internist and telemedicine specialist to ask for, now what? This is wrong, so, and this is wrong. So the right thing to do things, the right way to do things is, in terms of diagnosis, is let you work, you have to ask the questions you consider, and so on. And we have to transmit also the message to get a consensus on treatment. So in ophthalmology we have this, we have local treatments, and we have to suggest this treatment, and among all of us we decide and get a consensus on treatment. So I think that the multidisciplinary management of uveitis gets a global and optimal management of patients. There's an expert core which is constituted by the ophthalmologist, by the autoimmune disease specialist, by the pediatrician, but this core has to be connected with other specialists who at least have to have some interest in intraocular inflammation, because if not, we are lost. We as ophthalmologists have to take care of the relationship. We have seen how. And it's very important for us to transmit clear messages in order to diagnose properly the patients and to treat properly the patients. So internists and pediatricians is very important for us that they understand our vocabulary, and that's the part you have to study. And from the point of view of the organizations, the three sames, same day, same space, and same people. And thank you very much for your attention.